Here are my disclosures that certainly investigating this with yet another new potential tool, the Aqua Beam, as well as been part of the PRESERVE study for IRE. Nonetheless, is that some of this is hopefully familiar, but we know for most patients, prostate cancer is a multifocal disease. These are just several studies, but really showing that on final pathology, surgical pathology, that about 80% of prostatectomy specimens will have multifocal disease, even if we think that there's a main driver index lesion there, that we often find multifocal disease. And yes, we do know that there are poor prognostic factors that can help predict that. If you have multifocal, you're more likely to have extraprostatic extension, seminal vesicle invasion, et cetera. But actually, most tumors do still have a predominant lesion, and that index lesion, we call it, for most specimens, will be about just under 3 grams or 3 cc's in size compared to the other satellite lesions that determine it. And the concept of focal therapy is really making the assumption that index lesion is the main driver. Okay, we have to accept that in itself is usually the thing that is visible, and all that invisible disease isn't really significantly contributing. Certainly, many people have said is if you can't see it, it's not going to kill you. Right? And so certainly most significant tumors will have a visible lesion within their prostate as well. And so again, that thought that the index lever is really the site or driver that's going to lead for most patients to prostate cancer metastasis and ultimately read the rationale for mortality. And because of this theory that for certain prostate cancer patients where they seemingly have a predominant index lesion and for kind of low or if any other satellite lesions that we can find, that focal therapies have really come into play. And certainly I think we just heard is that those largely can be divided into kind of thermal and athermal type of things. And this is just a ever increasing list that we continue to see. But again, the problem with focal therapies is do we really want them to be focal, right? Even for a defined index lesion, you're always going to try to get a margin there, right? Because we know that there's the penumbra and the actual tumor itself. So there's an area that surrounds it that also usually contains tumor. So even though we call it focal, we still want to kill, if you will, a larger area of that prostate. And the problem is that there are various strategies and plans that have been proposed, but the more tissue that we ablate, the increased risk of side effects. And again, it depends if we're talking about a thermal or athermal type of technology, but nonetheless, there is for almost all of those increased risk of erectile dysfunction, increased risk of urinary symptoms and or bowel issues depending on the type of therapy that's used. And so does that mean we shouldn't consider it? And again, it is still considered on the more exploratory avenue, and there it will, I believe, find a home. But if you look for men with low-risk disease, and these are the guys who I always have stood up and said, don't touch them. They have low risk. Just follow them. It's pretty okay. But certainly there are going to be your very extremely motivated patients who saying, hey, you have higher volume Gleason 3 disease. Maybe we can prolong your time on active surveillance with these. And so again, there have been various arguments of why we should employ focal therapy in this space. But if you look at the outcomes for men who truly have lower risk disease, they're pretty good, meaning that the time, if you follow these, and this is just a meta-analysis review of it, but that you will see that there's grade group 2 or higher within field or out of field, meaning in that index lesion or outside of it, it's pretty reasonable, meaning that if you look at all patients who are treated with focal therapy with low-risk disease, only 12% will have in or out of field recurrence, which is pretty reasonable if you're going to go after those patient populations, but arguably, do we really need to treat those at all? So then we look at intermediate risk disease. And again, I think that this may be kind of the sweet spot which we're after if we're talking about as a primary therapy with curative intent. And again, focal therapy has really migrated towards that intermediate risk disease. MRIs have really kind of helped us, and maybe even PSMA scans, as we heard, to what our expectations should be. But if you look at this and you look at a modern day series, Dr. Reiter has certainly reported that using multiparametric MRI to diagnose the disease and subsequently treated 40% of those who have unilateral grade group disease, who were diagnosed and were thought that's all they had, ultimately when you took out their prostate, they had contralateral disease with grade group 2 or higher on the other side. So again, just saying that there is potential for significant disease, although invisible there. And when we look at a lot of the studies that is out there, and again, we kind of compiled this, and there are many studies that have now contributed, but the average kind of recurrence rate for treating grade group 2 disease with focal therapy is on the order between 30 to 50%. So round that out to about 40%, saying that, hey, I'm gonna treat you, but the fact that you can have an infield or out of field recurrence is about 40% over really on the next biopsy, but certainly over time that increases as well. So as long as we're counseling patients appropriately, saying that, hey, we're gonna treat you with that intent, but you may need additional therapies, whether that ultimately reverts to a more radical therapy, something that's more conventional, or whether that's repeat focal therapy, that's really the subject of debate. And again, this is the prostate cancer treatment trap that I was alluding to, is if you're gonna treat focally, the less you treat, the more you miss, right? So again, the probability of under-treatment is high if you just are focused on a specific area, but if you treat the whole prostate, that the chance of you successfully treating them is a lot higher. But again, the more you treat, the higher those comorbidities, and those are the things that why we're trying to use focal therapy to avoid those. So again, when patients recur, we have to decide, well, where do they recur? Does it make sense? And does that influence ultimately how we treat them? So if you have a infield recurrence, so you had an index for lesion, you went after that, and there's a recurrence there, does that mean we just kind of missed it? Should we kind of just retreat in the same area with that same technology? Even if it's on that same side, should we just treat it knowing that there's probably still a lower possibility of having side effects? Or do we, if it's contralateral, do we go after the whole gland, or do we offer focal therapy to the other side? And that's really where there's a paucity of data. You would think that there would be a more defined pathway at this point to say, hey, focal therapies have been used. They are certainly being used all the time in Europe, and certainly now across the US. Again, most of these are on trial basis, but again, many patients are interested with the selling point that they decrease morbidities. But when you have a recurrence, whether that's infield or out of field, you really have to take into account the patient's overall characteristics, right? If a patient has a lot of comorbidities, you're a lot more apt to treat with a focal therapy again, because you don't really want to expose them to a lot of the toxicities, and you don't really know what their lifespan is, and you're assuming it's 10 years, but again, we're not entirely sure. So taking into account their comorbidities and life expectancy is important. And then you also have to talk and be frank is saying, hey, you've had a focal therapy, and certainly if it's been ablative or radiation-based therapy, your probability of maintaining your erectile function or continence, if we're going to retreat you, may go way down. So their importance to lifestyle and their balance, if you will, with the cancer outcomes and importance there is a moving target. And then take into account, once you have that recurrence because you've biopsied them, what is the extent and what are you finding, right? What is the Gleason score that we find? That may not even be possible if we do radiation. They may not be able to grade that appropriately. But what is the number of cores that are involved? The tumor location, is it in the same index lesion? Is it ipsilateral? Is it contralateral? And then again, take into account the type of focal therapy that patient has. Again, remember, most focal therapy, ablative focal therapies will cause usually some scar tissue that may be more challenging if you're talking about surgical therapy as a a secondary therapy. So again, these are just important for you to take in account, and that's really why there's not necessarily a straightforward algorithm, because again, there's going to be a lot of variations here. So in general, again, I think you should, as a retreatment because of persistence or inefficient treatment, or certainly even if there's newer, that's disease, that's where you start thinking about more radical therapies. This patient has failed. We gave him a chance. So again, if you have a larger tumor volume, if it's bilateral disease or higher grade tumors, certainly I think it's a lot easier to have that discussion. So again, doing radical surgery, radiation, or whole gland ablation should then be considered, knowing that there may be an increased risk of side effects, but the balance there is that those patients maintained all of the advantage of having no side effects theoretically in the interim. And again, you can consider repeat focal therapies if you have lower volume disease recurrence or infield recurrence, or lower volume contralateral disease. So again, I think that this is a moving target. I think focal therapies as a whole is a moving target. I think as a primary treatment, there is a population that is more well suited for. And then again, I didn't talk about it, but the ProTech study really did highlight the fact that for intermediate risk disease, that at 15 years, there is equivalent outcomes, whether you had observation, whether you had radiation or surgery. So building upon that, I think, again, if you have a more limited volume grade group 2 disease, this may be a perfect candidate to kind of ensure that this patient may do better on active surveillance over time, or you can certainly delay that. So again, I do think that the treatment decisions that you offer should balance between the patient characteristics and tumor characteristics, the location of the tumor and the grade in particular, but understanding that if you offer more radical therapies, they may potentially be associated with a higher risk of side effects. Thank you.